Hello, ladies and gentlemen. Welcome to Triple N Cardiology Lectures. I am Dr. Nik Nikam. In this presentation, we are going to look at atrial flutter from basics to bedside management. At the end of this presentation, you should be able to recognize the atrial flutter and institute appropriate treatment in an acute or subacute situation. So let us begin. Atrial flutter is an arrhythmia which arises from the atria. Actually, it is created by a circuit which is circling around the tricuspid annulus, and this has a track which can go around in a counterclockwise manner or a clockwise manner, creating the typical sawtooth appearance of the flutter waves, the rate which can range from 225 to 320 beats per minute. That's the atrial rate. The ventricular rate could be 1 to 1, resulting in like 300 beats per minute, or it could be 2 to 1, resulting in 160 beats per minute, or it could be 3 to 1, where the ventricular rate may be around 100 per minute. It all depends upon the degree of blockade at the AV nodal level that creates the ventricular rate. So depending upon whether the electrical impulse is going in a counterclockwise manner or if it's going in a clockwise manner, it is defined as a typical flutter where we have a sawtooth appearance with a negative deflection which is prominent in lead 2 and 3. Whereas in a positive deflection atypical flutter or reverse typical flutter, we have a positive deflection in lead 2 and 3. Okay, when we are talking about atrial flutter management, the predominant things we need to be concerned about are symptoms. How symptomatic is the patient? What are the underlying conditions? Does this patient have heart failure? Does this patient have vascular problems? Does this patient have chronic lung disease? Because the treatment is going to be modified according to the patient's pre-existing medical conditions. How fast is the rate? Is the rate 300 per minute? Or is the rate 125? Or the rate 80 beats per minute? So atrial flutter comes in all flavors and all rates. So the treatment is highly focused to the patient's symptoms, rate, and pre-existing medical conditions. Again, vital signs. For example, blood pressure. Does the patient have adequate blood pressure? Does the patient have adequate saturation? Does the patient have good kidney function? And all these things to be taken into consideration when we are trying to manage patients with rate or rhythm control. Now, the next major question is, what is our immediate goal? This has to be very clearly understood. If one thing you understand from this presentation, I want you to walk away with the understanding of what is your goal in the emergency room, in the intensive care unit, or on the floor about dealing with atrial flutter in that particular patient. The first goal should be rate control. So let us not lose sight of what our goal is. So don't get overzealous and try to convert the patient into sinus rhythm, because you run the risk of blood clots getting loose from the atrial side and creating stroke, which is one of the worst possible complications of rhythm control unless we have excluded blood clots in the left atrial appendage by doing a transesophageal echocardiography. We will come to that in a minute. Then the urgency. Is the patient decompensated? Is the patient in a state of moribund shock? So those are the things we need to take into consideration. After that, once we have determined we need to get the rate under control, then we have to choose a drug. The drug that we choose has to have an immediate action, because you don't have time for 6 to 8 hours for the drug to take effect. We need to focus on drugs that can work intravenously in the presence of multiple organ diseases, and then we decide what is the most appropriate drug that will keep this patient under the rate under control, the vital signs in an optimal situation, make the patient comfortable, reduce the symptoms, then address the underlying issue, that is heart failure or pneumonia or COPD and all these other things which needs to be taken into consideration, or it could be myocardial ischemia. All these things need to be taken into consideration so that we have an acute plan, a subacute plan, and a long-term plan. So there should be 3 different phases. The moment we start the acute plan with intravenous drugs to immediately slow the rate down, at the same time we should be starting these patients on oral, longer acting or long-acting anti-arrhythmic drugs to control the rate. So we should be having sort of a multi-pronged approach when we are dealing with tachyarrhythmias with compromised vital signs. That's an important thing to keep in mind. This is what you don't see in textbooks. This is what you don't see in review articles. But this is something you learn a number of patients at bedside and realizing what is most important, patient's life. That's priority number 1. Priority number 2, maintaining proper vital signs. Number 3, reducing symptoms. And number intermediate and long-term goals. There are other ways to control the rate if it cannot be controlled with drugs, or if the patient is in shock, hypotension, or respiratory failure. We have other options like cardioversion, which we are going to touch upon in a minute. Keep these things in mind because these things are not explained in the textbooks. All right, let's move on to, let's look at some other drugs that are available to control the rate in an acute situation. Some other drugs that are used in an acute situation as an intravenous drug can also be used orally for long-term control of rate in patients with atrial flutter or fibrillation. So we need to understand a handful of drugs, maybe no more than 6 drugs we should be very familiar with, and we need to know how, when and where to use a given drug. Let's start off with adenosine. Adenosine is not the drug of choice for treatment of atrial flutter with a rapid ventricular response, especially if you're dealing with a patient with a heart rate of 160 who has compromised cardiovascular findings like hypotension or reduced renal output, altered mental status. So adenosine can be useful in trying to unravel the P waves. If we are not sure, if you have a heart rate of 160, you absolutely cannot see the P waves because they are buried in the T waves and the QRS complexes. Then we can try certain maneuvers like vagal maneuvers or carotid sinus pressure, or use adenosine just as a test dose to reduce the AV conduction for a few beats to see if we can identify the flutter waves. That's the only time when adenosine may be useful, but I would resort to much simpler techniques like vagal maneuvers or a carotid sinus pressure. If that works, then you don't need to do anything else because you know the diagnosis. Now the next step is immediate implementation of an intravenous protocol to bring the rate down, improve the blood pressure, improve the oxygenation, improve the mental status, and then at the same time start working on long-term oral anti-arrhythmic drugs. Okay, let's talk about metoprolol is a drug which we can use to see if we can slow the rate down to look for flutter waves. It can be given as a 5 milligram bolus. It usually acts within 5 to 10 minutes, but the effect lasts for only like 20 to 30 minutes. But it is associated with sometimes severe AV blockade, and you generally don't like to use beta blockers in patients with second degree or higher AV block. When you use metoprolol, we also need to be aware of the fact that it may have an adverse effect in patients with severe, advanced chronic obstructive pulmonary disease. Once we use this, let's look at some intravenous drugs, then we'll come to the oral drugs. Diltiazem can also be used, 15 milligram bolus, followed by 5 to 10 milligrams per hour IV. It slows the AV conduction, it slows the rate, and it helps to bring down the ventricular rate and stabilize the vital signs. However, calcium channel blockers need to be used with caution in patients with reduced ejection fraction, especially if their left ventricular ejection fraction is less than 40%. Diltiazem can also be given orally. We have long-acting diltiazem, which can be given in a dose of 120 to 460 milligrams per day. But we need to watch for the left ventricular function. It is useful in patients with a chronic obstructive pulmonary disease where we cannot use beta blockers because of potential bronchospasm or worsening of lung condition. Same thing with the metoprolol. Anyway, let's move on to verapamil. Acts similar to metoprolol, and it has the same side effects of causing hypotension, bradycardia, and also higher grades of AV block. The advantage of verapamil over metoprolol is that it can be safely used in patients with a chronic obstructive pulmonary disease where you are concerned about bronchospasm or worsening of oxygen levels. When these medications cannot be safely used because of various reasons, we also have digoxin, which can be used to control the ventricular rate. And of course, digoxin is going to take a couple of hours, 2 to 4 hours to start working, but nonetheless, it is an effective agent to reduce conduction through the AV node. Load the patient with 0.5 milligrams IV, and this is followed 6 hours later by 0.25 milligrams and a second dose of 0.25 milligrams 6 hours later. So over a period of 12 hours, you should be able to give 1 milligram of digoxin IV to load the patient with adequate digoxin level. When we are trying to control arrhythmias, we are not looking for normal therapeutic levels of digoxin like going up to 1.7 nanograms, but we want to keep it around 1 or below to minimize ventricular ectopic activity and other side effects related to digoxin. When we are using digoxin, it has to be titrated based upon the kidney function. If the creatinine is like 2 or 3, the digoxin dosage orally should be 0.125 milligrams 3 times a week. Watch for the side effects we talked about: AV blockade, arrhythmias. Those are some of the IV and oral medications available for rate control. I want to emphasize the word rate control. In the initial stage, our purpose is rate control. Now let's talk about atrial flutter rhythm control. When you are trying to take a patient with atrial flutter and convert them into sinus rhythm, we have a whole variety of ways in which we can convert this patient into sinus rhythm. The most important thing we want to make sure is there is no evidence of a blood clot in the left atrial appendage. So if you are trying to convert this patient into sinus rhythm on an urgent basis, either using drugs or using cardioversion, that patient needs to have transesophageal echocardiography before we proceed with the cardioversion. Generally, the setup is you do the transesophageal echocardiography, the patient is already sedated, then you do the cardioversion immediately following the transesophageal echocardiography if there is no evidence of a blood clot. If there is evidence of blood clot, these patients need to be started on anticoagulants and brought back 4 to 6 weeks later, then cardioverted based upon if there is a blood clot in the left atrium or not. There are some of the antiarrhythmic drugs that can convert the atrial flutter into sinus rhythm and maintain sinus rhythm over a longer period of time include propafenone, amiodarone, flecainide, and sotalol. So let's just briefly look at these drugs. You can pause the video and write down all the charts, or if you have a drug program on your smart device, you need to know the starting dose. But when you're dealing with a patient in the intensive care unit, you just cannot go and do literature search to see what's the dose you want to start these patients on. Propafenone is a class 1C drug. The starting dose is 150 milligram every 8 hours, or up to 300 milligrams every 8 hours, or a max of 900 milligram per day. It is used for atrial fibrillation and flutter. We need to watch for liver disease. Liver disease can alter the propafenone level and clearance. Amiodarone has been used for every kind of arrhythmia, from atrial flutter, atrial fibrillation, ventricular tachycardia, PVCs. This drug also has side effects. First of all, it takes a longer time for amiodarone to work. So if you are dealing with a patient with a heart rate of 225, this drug may not work. We may have to do cardioversion, or we may have to use other drugs to bring the rate down, stabilize the patient, then consider starting this drug in the early stages. You have to give like 1200 milligrams IV over a 24-hour period. You start off with a 150 milligram bolus, then an infusion at 1 milligram per minute for 6 hours, followed by 0.5 milligram per minute for 18 hours. Orally, it can be given in a dose ranging from 200 to 400 milligrams twice daily, or 800 milligrams twice daily. Orally, you almost have to give like 4.8 grams to totally load this drug. The clearance of amiodarone is very slow. It can stay in the system for 2 to 4 weeks in the body. So it takes a longer time to build the serum level to maintain an antiarrhythmic effect. The main side effect of amiodarone is pulmonary fibrosis. So we need to constantly monitor lab tests. And when we start these patients on amiodarone, we need to have pulmonary function tests done at least once. Flecainide is another antiarrhythmic drug. It is used in a dose 50 to 200 milligrams every 12 hours, used for maintaining sinus rhythm in a patient with atrial flutter. It can be used long term. However, we need to be cognizant of the fact that flecainide can make heart failure, there's a typo here, heart failure worse. So make sure that you have ruled out ischemic heart disease. Make sure you have left ventricular function data available before you start these patients on flecainide. Sotalol is like a beta blocker. It reduces AV conduction. It is used in a dose 40 to 80 milligrams twice daily. This is a significant side effect of sotalol, which is bradycardia and hypotension, especially in patients with a compromised left ventricular function. It can further aggravate their condition because of slowing of the heart rate and hypotension. We also need to monitor QTC interval, as sotalol has a tendency to prolong the QTC interval. Most of the antiarrhythmic drugs come with a black box warning. A lot of these antiarrhythmic drugs are pro-arrhythmogenic. That means they can create new arrhythmias which could be worse than the arrhythmia we are treating. So we need to watch for those black box warnings before we use. So I would say get familiar with a handful of drugs for treatment of atrial flutter or fibrillation. Know everything about those drugs, their action, duration, and side effects, and when to avoid those drugs. It will be a lot easier for you to deal with arrhythmias in an acute situation, in the emergency room, intensive care unit, or in the post-operative wards. How do we start off? First of all, we take a patient with an atrial flutter. First, we look at what is our treatment strategy. The treatment strategy should always be first, rate control. Second, rhythm control. Unless the patient is compromised in terms of vital signs, hypotension, hypoxia, then cardioversion may be the choice for getting this patient back into sinus rhythm. As far as rate control is concerned, we have a choice of beta blockers, diltiazem, verapamil, or class 1 antiarrhythmics. The rhythm control is going to be of importance once we have controlled the rate, and this is for a long-term solution. We can use catheter ablation. The success rate of atrial flutter ablation is in the range of 95 to 97%, and it's a fairly quick procedure so that these patients can avoid lifelong antiarrhythmic drugs and thus could be greatly benefited. As far as rhythm control, I talked about amiodarone, sotalol, and dofetilide, which is also an antiarrhythmic drug, can be used to keep these patients in sinus rhythm. Most of these drugs can prolong QT interval, so we need to watch all those side effects. And here we have a class 2B antiarrhythmic, namely flecainide, ropafirone, and we need to make sure the patients don't have structural heart disease when we choose flecainide or ropafirone. All right, ladies and gentlemen, this is again in a nutshell telling you how you approach a patient with atrial flutter. If the patient is hemodynamically unstable, then you go for cardioversion or rate control with the drugs we talked about, beta blockers, verapamil, digoxin, amiodarone. And if these patients had atrial flutter for greater than 48 hours, and if we are not sure how long the patients had been in atrial flutter, they all need to be started on anticoagulation regimen. If the patient is hemodynamically stable, we can try to control the rate with the IV drugs and then try to restore rhythm with cardioversion or pharmacological agents such as amiodarone, ropafirone, sotalol. When these things don't work, we always have catheter ablation. So, ladies and gentlemen, let's look at a couple of examples. Here we have a narrow QRS tachycardia at a rate of almost 160 to 165. We cannot see clear-cut P waves. I don't know if this is P wave or this is P waves. In these cases, slowing the rate will help us to identify what we are dealing with. And if you can see flutter waves when we slow the heart rate through carotid sinus pressure or through vagal maneuvers, then we can institute the treatment based upon pre-existing cardiovascular conditions, based upon patient's vital signs, and based upon patient's kidney function, among others. So always keep in mind, we talked about what drugs are available, we talked about what is the patient's condition, and what is the drug that needs to be used. When patients present with symptoms, which is usually the presentation, then we need to consider intravenous drugs to reduce the rate, while at the same time starting them on oral drugs to control the rate long term. And here's another example where the rate is going 300 per minute. It is a narrow QRS tachycardia. We are not sure what the rhythm is, but that is immaterial. If the blood pressure is 80, if the oxygen saturation is 80%, the patient needs cardioversion. And since he has a regular rhythm, a cardioversion with 200 watts should be able to get this patient out of this rhythm and back into hopefully sinus rhythm. And then we try to establish what is the underlying rhythm and how best to treat that particular tachyarrhythmia. So, ladies and gentlemen, here's another example where we have a rate which is like 125 to 130. So, this is kind of hard to say whether this is supraventricular tachycardia, sinus tachycardia, or are we missing atrial flutter with 2-to-1 conduction. And it looks like, there's a definite PR interval. And when we see these things, when the rate is between 125 to 160, we should always think about the possibility of atrial flutter with 2-to-1 conduction. If you are in doubt, look at the previous electrocardiograms. Look at if this patient had cardiac arrhythmias, look at the drugs the patient is getting, or repeat the EKG when the heart rate is slower, and look at the P wave morphology in that particular EKG compared to this one. The other option would be, if you are at bedside, you can try carotid sinus pressure or vagal maneuvers to slow the rate down and see if you are missing a flutter wave that is buried in the QRS complex. This may look like sinus tachycardia, but the reason I put this one is to emphasize the fact that when you see a supraventricular tachycardia at a rate from 125 to 160, always look for or exclude atrial flutter. So, ladies and gentlemen, you have been watching Triple N Media. I know this is a long-winded presentation, but this should give you all the diagnostic information that you need and the choice of appropriate drugs for management of atrial flutter in an acute situation on the floors and as a long-term management. Thank you so much for watching this presentation. Please do subscribe to our YouTube channel, and we will see you next time.